This podcast is not a replacement to any formal lectures or clinical placements.
Welcome back, everybody. Hope all of you are doing great. We are your hosts for today, myself, Sagun Gargi.
And I am Samikshya from Nepalese Army Institute of Health Sciences.
We are going to discuss a case on neurology today. We have a 55-year-old woman with the worst headache of her life.
This is the 8th episode of our case series, and you're listening to Behind White Coats.
A 55-year-old woman presented to the emergency department with the chief complaint of a headache for 7 hours. According to her, she was apparently well 7 hours back when she suddenly developed a headache while working in the field. She described the headache to be throbbing in nature, diffuse, and said that it worsened in the bright light. It was not relieved by taking paracetamol, which was easily available to her. She gave pain a score of 8 out of 10 and described it as, quote, the worst headache of my life, unquote. A little later after the onset, she started to feel nauseous and approximately 2 hours later had an episode of non-bilious, non-projectile vomiting. She also complained of mild discomfort in her neck, which was worsened by movement. She provided no history of fever, numbness, abnormal body movements. Talking about her family history, there was no past histories of similar headache in her family. She was a chronic smoker with 20 pack years.
The patient has given us the history of presenting illness. She has described her headache to us in best possible words. This is the point where we need to run our differentials. It is important to rule out some dangerous and emergency conditions which could have caused the headache. We will eliminate them one by one with more test results in our hands. We need to be alert and decide what tests we want to ask for first without losing precious time that we could have used to help our patient instead. The presentation being acute in onset should warn us enough about the crisis it could result in if we're not attentive. At this point, we can rule out a few types of headache which have chronic onset, but let's not throw them off the table just yet. We should move on to examinations now to help us narrow our diagnosis.
On examination, she is conscious but irritable and well oriented to time, place, and person. Her temperature is 98.7 degree Fahrenheit, blood pressure 140 by 80 mm of mercury, heart rate 82 beats per minute, and respiratory rate 18 per minute. Signs of meningeal irritation were present. On examination of the eye, she was greatly reactive to bright light, but her reflexes were normal and pupils equal and reactive, and also she had no papilledema. On neurological examination, she showed no signs of focal neurological defects and had normal deep tendon reflexes. On palpation, she had no signs of tenderness in the paranasal region and no signs of tenderness and decreased pulsation in the temporal region. Blood tests revealed complete blood count within the normal range with slightly elevated level of RBC, which was 5.9 million cells per cubic millimeter.
The further we go with the investigation, the closer we will get to diagnosing our patient. The above-mentioned examinations help us exclude few important conditions. The absence of fever helps us exclude infectious origin. Palpation findings exclude sinusitis and temporal arteritis. Now, temporal arteritis, it is another vicious entity we should watch out for. Normal neurological examination and absence of papilledema makes a case of brain tumor quite unlikely. Moreover, our patient had diastolic blood pressure less than 120 mm of mercury, which helps us exclude hypertensive encephalopathy as well. The history and examination findings, especially sudden onset of headache on exertion, make cerebral venous thrombosis to be a less likely cause. We still need to conduct imaging examinations to guide us accurately in our diagnosis.
And that is what we did. We performed a non-contrast CT scan, but it was inconclusive. The imaging showed no signs of abnormalities. So, after ensuring our patient was not contraindicated for a lumbar puncture, one was done, but the report came back normal as well. So we waited patiently for 6 hours while giving palliative treatment to the patient. Then did another lumbar puncture. This time, the results showed xanthochromia with opening pressure 28 cm CSF.
The acute onset headache triggered by exertion and the patient describing it as the worst headache of their life is vital information to suspect a case of subarachnoid hemorrhage. In any case, it is equally essential to rule out other dangerous cases. Now, in a suspected case, non-contrast CT scan is performed. However, a clear scan does not necessarily rule out subarachnoid hemorrhage, and thus it should always be followed by a lumbar puncture. In the result of lumbar puncture, we expect to see the yellowish discoloration of cerebrospinal fluid, something we call in medical terms as xanthochromia, but it can take as long as 6 to 12 hours to be properly appreciated. So a repeat lumbar puncture test must be done 12 to 24 hours after the onset of symptoms before ruling out subarachnoid hemorrhage. The basis of xanthochromia is the lysis of red blood cells present in the subarachnoid space and its subsequent conversion of hemoglobin into bilirubin. As is true in our case, lumbar puncture showing positive xanthochromia concludes our diagnosis to be subarachnoid hemorrhage. But that does not conclude our job, does it? We need to find the source of the bleed and manage it as soon as possible.
Yes, true indeed, which is why we conducted digital subtraction angiography, which revealed a saccular aneurysm in the right middle cerebral artery as a source of bleed.
Since the definitive diagnosis has already been established, shall we discuss SAH in general and then move on to the management of the case, Sagun?
Sounds great. Subarachnoid hemorrhage is extravasation of blood into the subarachnoid space between the bile and arachnoid membranes. The major causes of subarachnoid hemorrhage, excluding trauma, are rupture of a perianeurysm, arteriovenous malformations, extension from a primary intracerebral hemorrhage, mycotic aneurysm, or the cause may be idiopathic. It is a new pathology, hence patients often give history of no such headache in the past. The incidence is about 6 to 8 per 100,000 people per year, the most common age of presentation being 40 to 65 years old and is more commonly seen among women.
The risk factors include smoking, heavy alcohol consumption, preferably more than 2 units per day, uncontrolled hypertension with diastolic pressure over 110 mm of mercury, certain genetic syndromes like polycystic kidney disease and type 4 Ehlers-Danlos syndrome, and a positive family history. Even in our patient, she had an independent risk factor, that is, smoking.
The classical clinical feature is headache. Headache is often occipital or diffuse, sudden, often triggered by exertion, throbbing in nature, and may be associated with photophobia or vomiting with moderate to severe intensity. Loss of consciousness and seizures are common during the acute phase. Neck stiffness or pain may be seen due to meningeal irritation by blood in the subarachnoid space. A significant minority of patients will have a minor hemorrhage causing a sudden and severe headache within the 3 weeks leading up to the main subarachnoid hemorrhage, which we call as sentinel headache.
If the patient is not managed in time, it may progress to complications such as rebleeding, hyponatremia, cerebral infarction, hydrocephalus, cardiac ischemia, and hypothalamic dysfunction. Which is why, along with the definitive treatment for subarachnoid hemorrhage, other prophylactic medications should also be given to prevent further complications.
So, the first thing to do is to secure the aneurysm, which is what we did for our patient. It can be done either by endovascular coiling or by neurosurgical clipping. We opted for endovascular coiling in our patient. Additionally, we gave her nimodipine 60 mg per oral every 4 hours for 21 days to decrease cerebral spasm and subsequent ischemia. Mild sedatives and analgesics were continued until the headache was relieved. Electrolyte levels were constantly monitored along with other routine post-operative care.
Through an artery in the groin or in the leg, a tiny catheter is inserted and guided all the way up to the blood vessels in the head and into the aneurysm itself, where tiny platinum coils are passed. These coils seal the aneurysm and prevent it from growing or rupturing in the future. This process is endovascular coiling. In neurosurgical clipping, a neurosurgeon will make a small cut and remove a small flap of bone from the scalp and will shut the aneurysm using a tiny metal clip, which will heal over time and permanently seal off the aneurysm from the main artery. Whether to opt for coiling or clipping depends mostly upon the size, location, and shape of the aneurysm. But it also depends on the surgeon and the hospital infrastructures available, coiling being the less invasive of the two and one with lesser complications is preferred over clipping in most conditions. The patient in discussion received the former as well, which was endovascular coiling.
So, to sum up, we had a case of a 55-year-old woman who complained about the worst headache of her life and presented with other associated symptoms. Examinations were done, laboratory tests performed, and investigations were carried out, which narrowed down our diagnosis to a case of subarachnoid hemorrhage. Angiography was conducted next, which revealed an aneurysm in the right middle cerebral artery. The patient received both surgical and medical management, and she was discharged a week later after a routine set of checkups.
In this episode, we discussed the step by step approach in a case of an acute headache. What other medical conditions would you like covered? Write to us or drop it in the comment section below. We'll be back with another case discussion. But until then,
Stay safe and keep learning. See you soon.